Hello, my name is Carly McCrow, and I'd like to talk to you today about traumatic brain injuries. Traumatic brain injuries, or TBIs, occur when the head collides with the surface, is exposed to a change in inertia, or when a foreign body penetrates the brain, basically when an external force injures the brain. In terms of acquired brain injury, there are two main types of traumatic brain injuries. Open brain injuries, which are usually when a foreign body enters the brain, such as assaults, falls, accidents, abuse, or surgery, as seen here in an extreme example. And there are closed brain injuries, which cause internal pressure and shearing when a foreign body does not enter the brain and instead the brain is damaged by the impact, such as would be experienced in an assault, a fall, a car accident, or abuse, as seen in this video clip. The brain is composed of millions of specialized cells, called neurons, which when damaged can cause deficits. During a car accident, the brain essentially bangs around within the skull, causing a shearing effect between the white matter and the grey matter, which leads to neural disruption. Car accidents are one of the main causes of TBIs. These also usually result in diffuse brain injuries, meaning the injury can occur to a widespread area or several areas of the brain. Some closed brain injuries may be prevented, like wearing a helmet, for example, during sports such as bike riding, horse riding, and extreme sports. TBIs tend to be classified by severity and mechanism. Whilst all types of TBIs can cause long-term significant impairment, more severe TBIs are more likely to have lasting impacts. As seen in this table, there are three main severities of traumatic brain injuries: mild, moderate, and severe. These are classified using the Glasgow Coma Scale, which grades a person's level of consciousness, and post-traumatic amnesia, that being a time frame, and loss of consciousness, or time spent unconscious. A current model developed by the Department of Defense and Department of Veterans Affairs, who are responsible for significant TBI treatment and advances in the US, uses all three criteria to produce an index of severity, that being mild, moderate, or severe. Neural imaging can also be used to diagnose TBIs, looking for lesions and swelling, and judge the extent of the damage. Traumatic brain injuries have been around as long as there have been people. Just think of Cain. There have been evidence of treatment of TBIs as early as ancient times, where there have been skulls found in battleground graves with holes drilled into the fractures that suggests an attempt to treat TBIs. In the Middle Ages, some head injuries began to be known as concussions. Concussion symptoms were first systematically described in the 16th century by Berengario de Carpi. It was first suggested in the 18th century that intracranial pressure rather than skull damage was the cause of some TBI injuries and symptoms. This hypothesis was confirmed around the end of the 19th century, and opening the skull to relieve pressure was then prescribed as a treatment. Perhaps the first recorded case of personality change after brain injury is that of Phineas Gage, who survived an accident in which a large iron was driven through his head, destroying one or both of his frontal lobes, though miraculously he survived. Numerous cases of personality change after brain injury have been reported since. The 20th century has seen developments in diagnosis and treatment that decreased death rates and improved long-term outcomes. Modern hospital, scanning, and rehabilitation centres and assistive technologies have increased the ability for people who have suffered a TBI to get better faster. Emergency first responder treatment and procedures have had some improvement on mortality rates. Though once a TBI occurs, intervention as a first response is often less effective than the process of rehabilitation in terms of impact and deficits. There is lots of innovation and improvement made for people living with TBI in terms of assistive technologies. The assistance mainly depends on the type of TBI and ensuing deficits that have occurred. Every injury is different, and therefore each solution needs to be tailored. Applications abound and are still being developed that make it easier for people living with TBIs to function in a somewhat normal capacity. With facial recognition software, vibration alerts, and even eye tracking, this is expected to be an ever-increasing field that makes a real difference. Smart systems such as Google and Alexa have also made functioning with a TBI easier. While some of these technologies are recent and exist on the market today, these areas of innovation are where the future is heading in terms of disability assistance. Say, for example, NeuroNaid. Certainly, TBI is more complicated than the typical bruised brain that comes to mind. Unlike broken bones or bruised organs, TBI requires a complicated process of recovery. Just look at this little 3-year-old girl.
As you look at 3-year-old Callie Zetek, you wouldn't think just months ago she almost didn't make it. In December, the family was traveling back to their home in Seward from western Nebraska when their car hit a truck head-on during a heavy snowstorm.
I was 27 weeks pregnant at the time. The most I received was a laceration on the elbow. My husband died on impact, and Callie suffered a severe brain trauma.
Callie was rushed to the hospital where she was put in a drug-induced coma. When her brain continued to swell, Nikki had to make the tough choice to surgically remove the bone flaps from her brain, not knowing if her daughter would even make it.
I couldn't even imagine, burying my daughter at the exact same time as my husband. That was unbearable for me.
A month later, Callie moved to Madonna to start her rehab and got to come home at the end of March. Now she's making strides, learning how to walk and talk all over again.
To go from a 2-year-old who's running around rambunctious, normal 2-year-old, to a 3-year-old who, could not do anything on her own was really hard to watch. And so when she was able to take those first steps, it was just amazing.
Callie's brother Lucas was born with no complications and now is a source of support for his sister. For Callie, it's been a long road, but through her determination and downright spunk, she's making it one step at a time.
Thank you, Dad.
Callie will continue therapy at Madonna 3 times a week, but her mom said she will be starting preschool next month and is excited for her to get to play around with the kids and just be a 3-year-old.
A person with TBI is simply acting on how they see the world. Cognitive impairments due to TBI are very common, even in mild cases. Disturbance of attention, memory, and executive functioning are the most common neurocognitive consequences of TBI at all levels of severity. Disturbances of attention and memory are particularly problematic as disruptions of these relatively basic cognitive functions may seem to exacerbate more complex cognitive processes. Movement disorders that may develop after TBI include tremor, ataxia, which is uncoordinated muscle movements, myoclonus, which is shock-like contractions of muscles, and loss of movement range and control, in particular the loss of movement repertoire. The risk of post-traumatic seizures increases with the severity of the trauma and is particularly elevated with certain types of brain trauma such as cerebral contusions or hematomas. People with early seizures, meaning those occurring within a week of the injury, have an increased risk of post-traumatic epilepsy. People may also lose or experience altered vision, hearing, or smell. This can make the road to recovery challenging and long. Sometimes full recovery is achieved, sometimes there are lifelong deficits. Of course, there are social implications after experiencing a TBI. Changes can occur, such as behavioral changes, personality disorders, mood swings or having trouble with emotional regulation, and communication difficulties depending on what part of the brain has been affected. This may lead to difficulty in maintaining relationships, having a lack of empathy, or having an insensitivity, and this whole process can be very socially isolating. If the frontal lobe particularly has been damaged, the individual can experience a lack of self-control as there's no braking mechanism. This can lead to outbursts of anger with no filter and inappropriate comments made to family and friends without realizing their impact. The opposite effect could also occur, with the individual behaving as if they have no personality or emotionless. Of course, the changes caused by a TBI can have impacts on student needs in the classroom. First, let's look at the TBI student. Teaching kids with a TBI can be hard. Sometimes symptoms can be just the tip of the iceberg, are hard to spot, or you can be unaware of what's gone on to lead to this point. Always, there's a backstory. Some learning challenges in the classroom can include forgetfulness, lack of interest, headaches, irritability, slowed reactions, and depression. These challenges can make learning with a TBI difficult, but luckily as teachers, there's ways we can help. The classroom lighting may have to be changed to not be so bright and reduce eye fatigue. Light bulbs may also need to be changed to ensure there's no flickering, as this can trigger seizures. Distraction should be reduced by maintaining clean work areas and not crowding the classroom. Careful consideration may also need to be given to desk placement. It can also be helpful to eliminate noise or create a quiet retreat if the TBI student is feeling overwhelmed or too stimulated. Assistive technologies can be heavily utilised where there is a need, such as increasing font size, changing colours, presenting things more visually, and providing clear instructions and allowing more time for certain activities, or providing adjusted activities. To keep a student's attention and improve focus, you can use cue words such as "now we are" or "can you please". This may include transition words such as incidentally, for example, anyway, by the way, furthermore, and on the other hand. Dividing work to make smaller, more achievable sections can also help a student to focus and not feel frustrated or overwhelmed. You can also summarize the information to help memorization. Written instructions may also be provided to assist with memory problems. It helps if these are clear and brief. If the type of TBI you are dealing with involves communication or word mix-up, then these instructions may be more effective in visual form. There's a whole host of adjustments that can be made. This would mainly be determined by the age of the student and the severity or long-term prognosis of the TBI, a few examples of which are listed for you on the PowerPoint. Many children who sustain severe TBIs exhibit difficulty with social adjustments related to newly acquired language deficits in pragmatic communication. Programs designed for improving social skills have been successfully implemented in the school setting that include teaching specific skills such as initiation, topic maintenance, turn-taking, and active listening, using repeated practice and constructive feedback, and granting the opportunity to practice in a natural setting with peers, staff, and parents. Self-modelling and self-monitoring procedures can be combined with skills training by videotaping students during the practice and having students rate their performance on scoring sheets. Behavioural momentum is another strategy that has been used to increase positive behaviours and compliance in brain injury rehabilitation. Behaviour momentum involves making requests with which the students have a high probability of compliance before making a low probability request, which is otherwise likely the students may decline. It's important to also address the needs of the class as a whole. The class has a right to a continued high standard of education in terms of information delivery and individualised attention. This may look like involving a teacher aide so that your time isn't so consumed by the needs of the TBI student, or putting systems in place to streamline the rest of the class when your attention has to be focused elsewhere. It's also important to provide education and support to classmates, particularly if there are long-standing relationships with the TBI student. Because there can be major behavioural and personality changes, classmates may not understand why the person they knew has changed so much. Part of this involves patience, whether the prognosis is short or long-term. Classmates also need to feel like they can talk to someone, as they can be dealing with their own emotional struggles. There may need to be counselling or a support network established for these students. The degree of accommodation for a student who has suffered a TBI vary greatly. As you have seen, this is a complex and individualised condition. Hopefully some or all of what you have seen in this presentation may be of use to you in your journey with a TBI student. Please utilise this presentation should you wish to gather more information or interact with the resources. Thank you for listening. Goodbye.